Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Good afternoon, everyone, and welcome to the American Urological Association's presentation on the 2023 CPT and Evaluation and Management Coding Update for Urology. My name is Ray Wiesig. I am the Director of Policy and Advocacy for the AUA, and I oversee our RUC, CPT, and physician reimbursement activities. I will be today's Master of Ceremonies, and before we get started, I have a few housekeeping items. First, please note that the recording of this program will be shared in the AUA's Practice Managers Network online community, or PMN. The PMN has many benefits, including unlimited access to the coding hotline, access to the PMN private online community, discounts on education, and more. If you are not in the PMN and want to learn more, we invite you to visit auanet.org/PMN. Additionally, this webinar is meant to be interactive, and there will be time for Q&A at the end of the presentation. And with that, it is my distinct pleasure to introduce our speaker today, Dr. Jonathan Rubenstein. Dr. Rubenstein is the chair of the Coding and Reimbursement Committee for the American Urological Association. He is a board-certified urologist with Chesapeake Urology Associates in Baltimore, Maryland, and the compliance officer for United Urology Group. He is the CPT advisor for the AUA and part of the Telehealth Task Force, the State Advocacy Committee, the New Technology and Imaging Committee, and Public Policy Council. He has represented the AUA at the ICD-10 coordination and maintenance meetings, and has been part of the AUA's Urological Allied Healthcare Professionals White Paper Ad Hoc Work Group, the Electronic Health Record Work Group, and the Telemedicine Work Group. Dr. Rubenstein grew up just outside of Seattle, Washington. He received his undergraduate degree from the University of California, San Diego. He received his MD from Baylor College of Medicine, his general surgery and urology training at Northwestern University Medical School, and completed a fellowship in endourology and laparoscopy at the University of California at San Francisco. And with that, I turn this webinar over to you, Dr. Rubenstein.
Great. Well, thanks, Ray. So welcome and thanks everybody for showing up today. You know, every year our CPT code set gets updated, and every year there are new codes that urology and those who help code for urologists need to learn. And this year, there's some pretty significant changes. So I'm really glad you're here on this webinar. I'm going to go over some new CPT codes that are both new and updated CPT codes. That there have been some moderate significant changes, especially in percutaneous nephrolithotomy. They really have to understand the details of it to make sure we code correctly. I also need to go over E&M codes. There's updates codes, especially when it comes to hospital E&M coding. So let's go ahead and get started. So we're going to be going over percutaneous nephrolithotomy codes, which are revised. They're different. The way we're going to code them after January 1st is going to change. We have a new code for laparoscopic simple subtotal prostatectomy. That's for benign conditions. It's different than our radical prostatectomies for cancer. There's new and revised codes for staple and suture removal if done outside of a global period. And there's some new category 3 codes that are emerging technology codes. So we'll go ahead and get to it. Next slide. So percutaneous nephrolithotomy, these codes have been revised and updated. Next slide. The reason that these codes need to be updated is that they were old codes, and really percutaneous nephrolithotomy transitioned really more from an inpatient site of service to an outpatient or ambulatory surgical site of service. Yes, can still be done in the hospital, but we're not keeping people in the hospital like we used to. Also, there was a lot of confusion with the terminology. It was not very granular. The word ureteroscopy, nobody knew if it meant antegrade ureteroscopy, retrograde ureteroscopy, was imaging included. And there are also some new interventional radiology codes that came into existence a few years ago. And one of our codes that we commonly use was removed. And therefore, how would these all fit in and what was overlap? There are things where urologists were not getting paid appropriately and things we may have been getting overpaid. Nonetheless, they needed to be revised. So they were revised. So starting January 1st, 2023, the nomenclature will be changing for these two codes. And we're going to talk about which codes can be used and cannot be used at the same time, what's included and not included. Next slide. So one thing that CPT made very clear is that the dilation, the access into the kidney is separate and billable work. CPT codes 50436 and 50437, which is for the dilation of a tract to be able to access inside a kidney. to place endoscopic instruments has a value, but that value was included in 50080 and 50081 previously, and there was a lot of overlap. Retrograde access can also be performed, but again, it was rather confusing on whether these could or could not be used. So breaking and removing stones is separate work from the dilation and access. And also complexity really wasn't captured by stone size alone. People have branching stones, stones in multiple locations, and ureter stones. These were not appropriately captured, and it was confusing on what code to use. So therefore, these codes, again, were revised, with 50080 being up to 2 centimeter stone in a single location, such as the kidney, renal, pelvis. 50081 will be stones greater than 2 centimeters, or stones that are branching, or stones in multiple locations, such as the kidney, and stones in the ureter, or stones in the ureter, which is an increased level of complexity, or patients with complicated anatomy. Any of those patients, 50081 would be the correct code to use. Next slide. So, because these changed, we had to determine what is typically performed in these procedures and what is not typically performed in these procedures. And therefore, it is changing what is included in 50080 and 50081 and what's not included. So what is included is the work that's typically done, which is everything that's done antegrade. So whether we perform antegrade access into the kidneys, antegrade stone removal, antegrade ureteroscopy, antegrade stent placement, antegrade nephrostomy tube placement, that's all included. Also, with all new codes, radiologic supervision and interpretation will be included, like 50430, 50431, 74425. So if these are performed, do not report them separately from 50080 and 50081. However, what's not included, again, is the access and dilation into the kidney. So if one performs 50436, which is dilation of a previously established nephrostomy tract or wire, 50437, which is dilation with new access, 52334, which is the retrograde access, that's not included. Any retrograde work is not included, or open procedures if they're performed concomitantly. So those can be reported separately if performed by the urologist. Next slide. So again, our old descriptor was 50080, percutaneous nephrostolithotomy or pyelolithotomy with or without dilation. You can see dilation was included. Endoscopy, lithotripsy, stenting up to 2 centimeters, and 81 was over 2 centimeters. So the new descriptor is percutaneous nephrolithotomy or pyelolithotomy with lithotripsy, stone extraction, antegrade ureteroscopy, antegrade stent placement, nephrostomy tube placement if performed, which includes imaging guidance. And 50080 is for simple stones up to 2 centimeters in a single location, where 50081 would be anything that's complex. Stones greater than 2 centimeters, branching stones, stones in multiple locations, stones in the ureter, or patients with complicated anatomy. Next slide. If performing this procedure bilaterally, report 1 unit of 50080, 50081 per side or per kidney, regardless of the number of stones that are broken. So if performing bilateral 50080, you build both sides with modifier 50. If you're building 50080 on one side and 50081 on the other side, you can report each without a modifier. Next slide. Again, 50080 and 50081 include 50430, 50431, 50433, 50434, and 50435. The descriptors are there, so do not bill those procedures along with 50080 and 50081 if performed, as they are included. And we remember that we also have code 50561 for removal of a stone without the use of lithotripsy. Next slide. So let's talk about some scenarios. If we have an interventional radiologist who places an access and dilates the tract, there's some centers where radiologists will place the access and go ahead and dilate the tract. The interventional radiologist will bill 50437. The urologist, they perform the nephrostogram, lithotripsy, and extraction of up to 1.5 centimeter kidney stone, places an antegrade stent or places a tubeless, however they leave it. the urologist would code 50080. Next slide. If the radiologist again accesses and dilates, 50437. If the urologist performs lithotripsy of a 1.5 centimeter stone in the kidney and a 1 centimeter ureter stone, and again, whether they place a stent or tubeless or nephrostomy tube, the urologist would bill 50081 because this is now a complicated procedure. Next slide. If the radiologist places the wire or nephrostomy tube but does not dilate the tract, they would bill 50432 whenever that was performed. If the urologist performs the nephrostogram, dilates the tract, performs a lithotripsy of the 1.5 centimeter stone and the 1 centimeter ureter stone, again, whether they leave a tube, whether they leave a stent, however they want to leave it, all antegrade, the urologist would bill the 50436 for the dilation of the previously established tract and 50081 for the complex nephrolithotomy. Next slide. If the urologist places the access, dilates, places a sheath, performs a lithotripsy of multiple stones or a large stone, and whether again leaving the stent, leaving the nephrostomy tube or tubeless, the urologist would report 50437 and 50081, with 50437 being a dilation of the tract with new access. Next slide. That's a urologist places the access, dilates the tract, performs a complicated nephrolithotomy, and then also needs to perform a retrograde ureteroscopy of a 1 centimeter ureter stone with a retrograde stent placement. The urologist will bill the 50437 for the dilation with new access, the 50081 for the complex nephrolithotomy, and 52356 for the retrograde ureteroscopy, laser lithotripsy, and stent placement. Next slide. Now the RVUs, you can see the difference between the current work RVUs and the 2023 work RVUs. What we have to remember is that 50436 and 50437, if performed, can also be reported separately. And so can any retrograde ureteroscopy or any other work that's done not in an antegrade fashion. So please remember that when reporting these services. Next slide. So now I want to talk about the new Category 1 code for laparoscopic simple subtotal prostatectomy. And I know that people out there probably saying, what took you guys so long? Sometimes these things take a little while to get them done right. Next slide. So to perform a laparoscopic simple subtotal prostatectomy, again, this is for BPH, for benign conditions. This is separate from a laparoscopic radical prostatectomy, which is done for cancer. Previously, an unlisted code was used to report laparoscopic simple subtotal prostatectomy, whereas CPT codes 55831 and 55821 are open codes. Now we have to remember for laparoscopic, whether it's done retropubic or subpubic, suprapubic laparoscopically, that's all considered a laparoscopic approach. So there's not a separate laparoscopic retropubic and laparoscopic suprapubic, but rather any technique that's performed laparoscopically, the approach is laparoscopic, whereas the open codes have both a separate retropubic or suprapubic approach with accompanying CPT codes. Next slide. So the descriptor of the new code 55867, and probably many of you out there remember that 55866 is our laparoscopic radical prostatectomy code. CPT code 55867 is our laparoscopic surgical prostatectomy, but our simple, instead of radical, subtotal prostatectomy. And again, if anyone does any other procedures, controlling bleeding, performing a vasectomy, meatotomy, urethral calibration, internal urethrotomy is included if performed at the same time. And again, 55867 includes robotic assistance when performed. There's a note in the CPT code book that tells coders for an open subtotal prostatectomy, whether retropubic or suprapubic, to see 55821 or 55831. Next slide. Again, previously we'd be using an unlisted procedure such as 53899, And now if one performs a laparoscopic simple subtotal prostatectomy, it'll be 55867. Next slide. And again, 55866 is a laparoscopic retropubic radical prostatectomy. And there's parenthetical notes that talk about if you're performing a laparoscopic, if an open prostatectomy, 55840. And also there's notes that describe how to go to laparoscopic surgical prostatectomy for a simple subtotal prostatectomy using 55867. Next slide. The RVUs, 55821 and 55831. Whenever a new code is valued, the family of codes also is valued. You can see the current and the updated RVUs. These were all finalized. These same RVUs are final RVUs for 55821, 55831, 55866, and 55867, which is our new code. Next slide. I want to talk briefly about the removal of sutures and staples not requiring anesthesia. Next slide. And the reason for these codes was there's a new set of hernia codes that does not have a postoperative global, a 90-day global any longer, but rather, and that's the way a lot of new codes are going, where there's not a prolonged global period. And there was no way of capturing the work done of removing sutures and staples that was now outside of a global period, not only for the work, but also the cost of the suture or staple remover. So there were codes that were used, 15850 and 15851 for suture and staple remover, but that would only allow it to be done under anesthesia. And that was either done on the same surgeon or different surgeon based upon the codes. But there are no codes that existed if it was done local in the office or ASC setting, and no way of covering the cost of the staple remover, which is a legitimate cost. So for 2023, CPT code 15850 will be deleted and 15851 will be revised and remove the reference to another surgeon. So it can be the same surgeon under anesthesia for 15851. However, there's two new codes, 15853 and 15854. And these codes are add-on codes to be performed at the same time as an evaluation and management service. And this is for suture or staple removal not requiring anesthesia. Again, this is to capture the work of performing the suture staple removal if it's outside of a global period and the cost of the suture or staple remover. Next slide. These new add-on codes, 15853 and 15854, need to be reported at the same time as an evaluation management code. And these two codes cannot be reported together because there's overlap between the codes. 15851 is not intended to report suture staple removal to reopen a wound prior to performing another procedure through the same incision. And again, suture and staple removal is typically included as part of a global period. So these should only be reported if performed outside of a global period. Next slide. So before January 1st of this upcoming year, again, 15850, 15851, remover of sutures under anesthesia, same or a different surgeon. And after January 1st, 15851, again, will be remover of sutures staples requiring anesthesia. 853 and 854 is remover of sutures or staples. And 854 is remover of sutures and staples. Both those are not requiring anesthesia. Next slide. And let's talk about a couple of new category 3 codes we may hear about. Next slide. So category 3 codes are emerging technology codes, and oftentimes these are procedures that are done either on a clinical trial or they're still trying to determine the usefulness of these procedures. You might see a new BPH procedure, transperineal laser ablation of BPH, which includes imaging guidance. And there's two procedures, they're related codes for magnetic field induction ablation of prostate cancer. One's for the planning and one's for the actual procedure. And again, if you're approached about performing these procedures, you know there is a category 3 code which should be reported to document that these procedures were being performed on a patient. Next slide. I just want to briefly talk about a couple updates. Now, these are not new codes, but I just want to talk that there are updates to the APC, the ambulatory payment classification of two procedures. And one is the ITIN procedure and one's HIFU. ITIN, which does not have a category 1 or category 3 code, but has a C code that Medicare can reimburse the facility fee. The APC went up from level 5 to level 6, increasing the payment in both the ASC and the hospital for the facility fee. And similarly, HIFU, which we know is category 1 code 55880, also went up from level 5 to level 6, which increased the reimbursement in hospital and an ASC setting. So that's just to make you aware that those changes did occur starting January 2023. Next slide. I really want to spend a few minutes now talking about evaluation management changes for 2023, because again, some big changes have come up, especially for anybody who is doing any work in a hospital setting, and also people who are seeing office consultations. Next slide. So if you remember back in 2021, our new and established patients in the office setting, everything switched. And it went from needing our click buttons, our 4 items on the HPI, a certain number of physical exam clicks, and we had this old medical decision-making chart. And that was updated for 2021 on a system which just made a lot more sense. Well, after the first 2 years and realizing, hey, this actually makes sense and this is good, we need to now expand this and have other E&M services follow the same pattern and the same guidelines. Well, we finally now have it for both office consultations and for hospital visits. So office consultations, and again, there are still insurers that pay for consultations, previously were not updated through the 2021 guidelines, but starting January 1st, 2023, are updated to the same 2021 guidelines. So not only are office consultations and hospital inpatients and consult codes updated, but we need to understand that the way that we'll use them now for office consultations and hospital consultations and inpatients will now align. So we have to have the same one system across really any place that a urologist or someone who's practicing urology will be performing evaluation and management services. So next slide. So if we remember our 1995, 1997 guidelines, we needed 4 history descriptors, an examination that met certain criteria, and we would choose a level based on time or complexity, which is history, physical examination, medical decision-making. And then our time, if we're using time, it'd be face-to-face in the office, more than 50% is counseling, coordinating care, and the total time in a hospital, and there are no real good add-on codes. Starting in 2021 for our outpatient, or 2023 for our office consultations and our hospital visits, our history needs to be a medically appropriate history. Again, you don't have to hit a certain number of click buttons, but it has to be medically appropriate. The examination, similar, it has to be medically appropriate. You don't have to hit a certain number of click buttons, but you have to document what's appropriate. When choosing the final level, it'll either be time or medical decision-making. Medical decision-making has 3 sections: the problems that are being addressed, the amount of data that's reviewed and or ordered, and the patient risk. And then time is now going to be a minimum amount of time. In the office, it'll be the total time spent on that day, and in the hospital, it'll be the total amount of time spent on that day. We no longer have a requirement for a certain percent to be counseling or coordinating care. And there are add-on codes, and the add-on codes are for each 15 minutes. As you can see, there's add-on codes that will either be for 99417 or G2212 if you're in the office. G2212 is our Medicare add-on code, and 99418 or G0316, again, Medicare for G0316, is for our hospital add-on code. That's for every 15 minutes above the maximum amount of time, which will be the highest level that you can get. And I'll show you on our chart in a couple slides from now. Next slide. So if you remember our medical decision-making chart, for those who remember this chart, this is the 2021 guidelines. You have to hit 2 out of the 3 sections must hit a certain level. So if you have a 4 on one section and a 4 on another section, the patient can be a level 4. To make a patient a level 5, 2 of these 3 sections have to hit a level 5. If 2 of the 3 sections hit a level 3, then the patient's a level 3. If you have a 2, a 3, and a 4, the patient is going to be a 3 because at least 2 of the sections made a 3. If you have a 3, a 4, and a 5, the patient will be a 4 because 2 of the 3 sections hit at least a level 4. I'm not going to go through the nuanced details of this chart, but for those who understand this chart and how it works, this is going to be the same chart for our office consultations and now for our hospital visits. Next slide. So let's talk about our outpatient consults. So again, our old language, or at least up to January 1st, office consultation, which requires history examination, medical decision-making, and face-to-face time. Starting January 1st, 2023, be a consultation with a medically appropriate history, medically appropriate examination, and a certain level of medical decision-making, level 2, level 3, level 4, or level 5 medical decision-making based upon the medical decision-making chart on the previous slide. If using a total amount of time on the date, a certain amount of time must be met or exceeded, and I'll show you that chart in just a minute. Next slide. So here it is. Again, 99241, just like it's going to be eliminated, just like 99201 was eliminated. So we're going to have 4 levels of office consultations: level 2, level 3, level 4, level 5. History examination must be appropriate. The medical decision-making complexity will be straightforward if 2 of the 3 sections hit a level 2. Will be low if 2 of the 3 sections on the chart hit a level 3. Moderate if 2 of the 3 sections hit at least a level 4. And 5 if 2 of the 3 sections hit at least a level 5. So the amount of time needs to be met or exceeded is listed here on the chart. 20, 30, 40, and 55 minutes must be met, and that's the total amount of time spent on that data. It does not have to be face-to-face time. So for example, a 40-minute consultation, if you spend 15 minutes prepping the chart and gathering bullet information, and 15 minutes seeing the patient face-to-face, and 10 minutes counseling and coordinating care afterwards, that's 40 minutes. The patient will be at 99244. To use the add-on codes, which is 99417, you have to hit at least 70 minutes, which is 15 minutes above the 55-minute level. And the reason I didn't put the G code for Medicare is, remember, Medicare does not allow consultations any longer. Next slide. Now for hospital, there's 2 major changes. Not only is the medical decision-making chart aligning with the 2021 E&M guidelines for outpatient visits, just like we spoke about, but there's no longer be multiple code sets. Observation codes and inpatient codes have been combined into one code set, which is going to be a big relief for those who are very confused about choosing a code for observation or inpatient status. We actually looked, the complexity was the same, time was the same. There was no reason to have 2 sets of codes. So they did the smart thing and combined them together by basically eliminating the observation code set entirely and renaming the inpatient code set. Next slide. So up to this point, or up to January 1st, again, I'll use an example: initial hospital care, which requires a certain amount of history, certain amount of examination, certain amount of medical decision-making, counseling and coordinating care, and amount of time. That's all stuff that's done on the floor. Starting January 1st, 2023, these codes will now read: initial hospital, inpatient or observation care per day for the evaluation and management of the patient, which requires a medically appropriate history. You have to hit a certain number of click buttons, a medically appropriate examination, and a certain level of medical decision-making based upon the exact same medical decision-making chart that we use for our 2021 guidelines for outpatient. And when using total time on the data service, X number of minutes must be met or exceeded. That's a total amount of time that's spent on that patient on that day. Next slide. I'm sorry this was a big busy chart, but I hope that it is simple once I kind of point out what it is. Let's start with our 3 initial codes. And again, we went from having 2 different code sets to 1 code set. So our initial codes, 99221, 22, and 23, initial inpatient or observation care. So whether the urologist is the one who's admitting or is the one who is the consultant seeing the patient for the first time, for insurance does not allow consultation services. The initial time of the patient is being seen, 99221 through 99223. Again, history and examination is appropriate. Complexity, straightforward or low would be level 1, moderate is level 2, and high level complexity is level 3. So again, maybe a 2 or 3 would be a 99221. As we remember, our 3s will be moderate, or 4s will be moderate, which is 99222. And getting 2 level 5s will be a high complexity, be 99223. You can see here is the amount of time, 40, 55, or 75 minutes must be met or exceeded. And again, we have our add-on code 99418 for services greater than 90 minutes. The next 3 codes are subsequent day, initial or observation care, 3-1, 3-2, or 3-3. And again, history and examination must be appropriate. Our complexity, lower straightforward, moderate or high, and the amount of time, 25, 35, or 50 minutes. And if you exceed 65 minutes, the add-on code 99234 through 99236 is if the patient is both admitted and discharged on the same day from either inpatient or observation care. As we know, that's more work than either admitting or discharging a patient. So same day admit discharge is more work. So you use 99234 through 99236. And again, the same straightforward or low, moderate and high with the 3 levels, 45, 70, 85 minutes, and the add-on code if over 100 minutes. Our 2 discharge codes are still there, unchanged, 9823, 99239. The difference is inpatient or observation discharge if on a subsequent day and from the admitting service. And again, the 5.2 through 5.5 are our inpatient observation consultations that should be used for insurers that still allow consultation services. And again, these are the 4 levels, just like our outpatient consultation services. History and examination are appropriate, and complexity and the time is all listed on this chart. Next slide. So let's go through some of these scenarios. Next slide. Let's say a patient is in the ER with a stone in the ureter, a very common thing to see in urology. The patient was brought in to the hospital due to pain, underwent a cystoscopy and stent placement, and was discharged the same day, so same day admit discharge. But the patient was actually brought into the observation unit while waiting to go to the operating room, but did go home that night. I would use a code such as 99235, which is the same day admit discharge from inpatient or observation status. In this case, the patient was in observation status. Again, adding modifier 25 for the appropriate insurers onto CPT, onto the E&M code 99235, because the CPT code 52332, which is 0-day global, was performed on the same day. Site of service is the observation unit. Next slide. Similar patient came to the ER with a stone. Let's say they were brought into the urology service because of pain and underwent the cystoscopy and stent placement next day. Again, if the day 1 bringing in for initial inpatient or observation would be a 99218 through 99220. Excuse me, those would be our observation, that'd be our old one. So we now use 99221 through 99223 instead of 99218 through 99220. And so I'm sorry about that error on the slide. The patient underwent a 52332 the following day and discharged from the recovery room. The discharge at that point would be part of the 0-day global. It's not separately identifiable. Next slide. The patient is seen in the ER with a ureter stone. The patient was brought into pain but had fever and sepsis, and the patient underwent a cysto and stent that night. Now again, 99221 through 99223 would be the initial admission service. Again, I would append modifier 25 onto that service because the cysto stent that was performed. Day 2, the patient's still in the hospital. We would use a subsequent day code. And day 3, they were discharged from the urology service, we'd use one of the discharge codes. Next slide. Patient seen in ER was admitted to the medical service with sepsis, and urology was consulted. Urology performed cystostent, and we saw the patient the next 2 days. Again, 99221 through 99223 would be the initial visit from the urology service. If it's Medicare or an insurer that does not allow consultation services, if it's an insurer that allows consultation services, 99251 through 99255, appended with modifier 25 because the cystostent performed on the same day. Urologist sees the patient the next 2 days, would bill a subsequent inpatient or observation code. If the medical service discharges the patient, the urology service would not bill the discharge code. Next slide. Those are my slides. So now I see there's a number of questions here, which we will start answering.
Thank you so much, Dr. Rubenstein. This is incredibly helpful, I know, for everyone. And based on the questions, I believe everyone's really appreciative of your time. For those of you who have asked about our slides and whether they'll be shared, I just want to address that really quickly because we've gotten several questions. The slides and the recording of the webinar will again be placed in our Practice Managers Network online community where you can view and download the slides there. So that should answer that question for you. I'm going to go ahead and just kind of go down the list of what we have. And so the first question we had is, for the simple prostatectomy, is the robotic approach a separate code?
No, okay, so it's a great question. So the CPT code 55867 is for a laparoscopic simple prostatectomy with robotic assistance if performed. So whether doing a non-robotic or robotic laparoscopic simple prostatectomy, CPT code 55867 would be the correct code to use. There's no modifier, no S code to add on for using the robot because it is included in the procedure itself.
Thank you so much. Our next question: a patient has robotic surgery with a 90-day global at one hospital, and patient follows up post-op in global period for follow-up with a different urologist in a different system. How would one code E&M appropriate?
Okay, so that's an excellent question. So again, the question was, what happens if surgery is performed at another institution and now follows up with you? So it all depends. It depends if there was an agreement or not in place. So for example, there are some urologists who have an agreement with a medical system that urologists do the pre-op work, the urologist at maybe at a major hospital in the city performs the surgery, and all the post-op care will be performed by the initial urologist. If that is something which is planned in advance, where all the post-op care will take place at the initial urologist, and none of the post-op care is going to take place at the surgeon performing. If it's planned that way, there are modifiers that should be placed on both the CPT code itself, the 55866, and the post-operative care, so they know that everyone can sort of split, because as we know, all procedures, let's say CPT code 55866, maybe like 80% of the value is for the surgery itself, about 20% of the value is for the pre and post-operative work. Well, obviously it's not fair to have somebody who doesn't get their fair share of the value. But if that's known in advance, both the surgeon at the major hospital should put the appropriate modifier on their CPT code 55866, and appropriate modifiers can also be placed on the E&M visits at the initial urologist service. Now, if the patient decides not to follow up with their original urologist, there's no agreement in place, then you can bill because the global period does not apply to you. What I mean by that is, if I send somebody downtown, they're just unhappy with their care and they come to see me, it's a new patient to me. The global follows the surgeon or the surgeon's group and does not affect another urologist outside of that group.
Excellent. Thank you so much. Next question. Will a modifier be needed for retrograde procedures with PCNL?
All right, so great question. Will a modifier be needed for retrograde procedure with PCNL? So again, we talked about that PCNL, if you actually look at the new wording, it specifically states antegrade stone removal, antegrade ureteroscopy. So while a retrograde approach is not included in the service, it probably wouldn't hurt to put a modifier, 59 modifier, an excess modifier on it for certain insurers. Obviously, it all depends on whether or not we start seeing denials or not. It is, and we're probably actually going in for a different stone at that time and a different approach. It's a great question. I'm going to start looking for denials after January 1st, 2023, but placing a 59er excess modifier is not a bad idea to do that for the insurances that typically want that, such as Medicare.
Fantastic. And of course, if something happens along those lines, we can always provide an update through our blog or network. The next question I have, should a medically appropriate history and exam always be documented? For example, the CPT book has verbiage within 99221 for initial hospital inpatient or ORBS care per day for the evaluation management of a patient, which requires a medically appropriate history and or exam, and MDM straightforward.
Right. Okay, so it's a great question. So the question is, what I'm going to paraphrase this. What do we have to really document when doing these things? You know, honestly, there's a lot of good reasons to perform a medically appropriate history and a medically appropriate examination. It's not just for billing purposes. It is for medical legal purposes. You know, if one does not document any examination at all, and God forbid there was a medical legal concern with the patient, they're going to question whether or not you actually saw and examined the patient. So for medical legal reasons, document what you do. If the patient is alert and oriented ×3, document the patient's alert and oriented ×3. If they're breathing, if they're mentating normally, you know, that's all you need. If you're talking to them and they're breathing regularly, that's a very appropriate examination for multiple reasons. So I strongly recommend that people document what they talked about with the patient and document the examination that's pertinent for the care of that patient. And again, it's just good medical care. You know, if you look and if you're trying to communicate to other providers and to know what you're thinking, just document well. Again, these new guidelines were not meant to just have people just swing and miss on the history and examination. It just made it so they weren't getting discredited if they accidentally only clicked 3 boxes. But the goal is really to document, allow a physician to document what they're doing on a patient. So do a good job on the history and the examination for multiple reasons, not just for billing purposes. But yes, hypothetically, if you didn't document an examination, you wouldn't get knocked down on the billing, but somebody would look at you funny.
Thank you. Next question I have is, in terms of how the AUA and your role as CPT advisor engages with these codes, could you maybe briefly describe the work involved in kind of coming up with these codes and working with the AMA?
All right, so that's a great question. Thank you for asking that. So, you know, the AUA has some really amazing teams and some really great urologists who work on these teams. And our goal and our job is to really protect urology services and protect urologists, and to also, describe the work that's being done so that our service can be appropriately valued. So there are 2 main groups of folks at the AUA who do work. There's both our CPT team that helps create CPT codes, and our RUC team, which helps appropriately value our codes at the RUC. And those are both parts of the AMA. And from the AUA, we have a group, our Coding Reimbursement Committee, which is around 15 folks plus a number of outside experts, help new technologies get codes as appropriate, help create new codes and remake codes when we are asked to do so. For example, these percutaneous nephrolithotomy codes, we were advised by the AMA and by CPT that we needed to revise these codes because there was so much confusion and because the main site of service changed. So we got together a whole bunch of experts. We looked at what other codes could or couldn't be used, what is or isn't included, and came up with a game plan that gave the appropriate wording so that we could appropriately get valued for the work that we do when performing these procedures. So it's a complex undertaking, because while we're fighting for one code, sometimes you have other services, other specialist societies who kind of push back a little bit here or there because they want to make sure that you're being honest about your codes and the such. It's a fun game, but I think it's a really important game to help make sure that we get appropriately valued for the work that we do.
Thank you, Dr. Rubenstein. And I will mention Dr. Rubenstein did win an award from the CPT panel for his work with the panel last year, and we're very proud of him for that. Next question I have, for total time, is time spent acquiring outside records by MAs able to be included?
Okay, so it's a great question. All right, so excellent question about ancillary staff, medical assistants acquiring, doing time. So it really describes the personal time that's being spent. So yes, if a medical assistant is gathering up the old records, that time cannot be counted for total time. The amount of time that the provider spends reviewing those records does count. There is also can be some overlap with a advanced practice provider, someone who, another qualified healthcare professional who can bill for services. So there is overlap. If a advanced practice provider spends 20 minutes reviewing the charts and then summarizes it to you, you can use that 20 minutes to add on for the time. But medical assistants and other clinical staff cannot.
Great, thank you so much. Next question, while performing PCNL of renal stones, if your renal stone is also extracted, is this included, or can we also use 50561?
Great, awesome question. So really, when performing percutaneous nephrolithotomy 50080 and 50081, that's all inclusive, meaning if you grab some stones and break up some stones, that'll all fall under 50080, 50081. But what it sounds to me is that if you, again, 50081 is for multiple stones. So you end up extracting one and lasering another or vacuuming out another. That would be 50081 because it's more complex because you're removing more than one stone.
Fantastic. Next question. Wouldn't you bill a 99223 for a septic patient with AKI?
All right, so it's a great question. So when looking at the medical decision-making chart, because you're asking about 99223 for a patient who's septic. So if you go down the medical decision-making chart and you look at the presenting problems, you look at data ordered and or acquired and the patient risk, if you really get down to it, a septic patient would probably make it to be a level 5 for the presenting problem. It's an acute issue that potentially could be life-threatening. And again, you're going to be starting the patient on medications, high-risk patients. The patient eventually would probably get to be 2 level 5s, which would be a 99223. You're exactly right. Now, again, this isn't blanket, but just I always pull out my medical decision-making chart and I go down the chart, those 3 columns, and I sort of like make sure I check off the right boxes to ensure if the patient meets that criteria. But that I guess that sounds it sounds pretty. Most patients would qualify for that. Yes.
The next question. If you see a post-op patient within the global of a colleague in a separate urology group while providing call coverage on a weekend, can you build 99231?
No, that's a great question. So another great questions. So the question is, what happens if you have a separate urology group that you guys are sharing call? If you actually look at the guidelines, the goal is that for the weekends that you're sharing call, the consideration is that you're considered one group. Yes, you are separate tax IDs and billing numbers, but it's sort of the intent of the idea that you're sharing call because you'll be giving up some and they'll be giving up some in reverse. So you should not be billing that, even if it is a separate group. Now, if it ends up that someone in the group, someone ends up in a different hospital and they don't cover, you can bill for that because then that wouldn't be the intent that you're covering for them. Next
question then. Do we have to bill an E&M with other office suture staple removal codes, or can 15853, 15854 be billed alone? Does modifier 25 have to be added to the E&M?
Right. So it's a great question about the suture staple removal. So the 15853 and 15854 are add-on codes to an E&M visit. So even if it's a low-level visit, 99212, you need to have the E&M visit to bill the 15853 or 15854. And you might say, hey, that's somewhat counterintuitive. The patient's just coming for the staples and walking out. Why can't you should bill it and save the insurer a little bit of money. That's just how they're written. And I guess the reason is to see and examine them, assuming that you're also examining them anyways to make sure that they're healing up well and to ensure that it's okay to remove the sutures and staples. That's my hunch, but they are add-on codes and they have to be added on to an E&M visit.
Next question, would you need to add modifier 25 to E&M when using 15853 or 15854?
Another great question about this E&M codes and using 15853 and 15854. Since 15853 and 15854 are unique, that they are add-on codes, they can only be used with 99 with a E&M code. So you should not need to add a 25 modifier onto it, because the way they're written is that they're not supposed to be used with a 25 modifier. Now, there's going to be some insurers out there that are probably going to try and pull a fast one. And so ultimately it's going to be, you do what's right based upon the insurer that's trying to deny payment for services, but based upon how the CPT codes are written, you shouldn't need to use a modifier 25 on them.
Next question, I often receive RUC surveys. What is the importance of filling out these surveys? And if I don't have all the information, should I not complete the survey?
So another great question, and thank you guys for asking this. So we talked about what the AUA does, and we help create CPT codes, and we help make sure that CPT codes are appropriately valued at the RUC. But for the RUC, we need the help of urologists who perform these procedures, because we need to know what typically is done in these procedures, the typical amount of time, the typical amount of effort. Now we have to get a certain number of these to be able to present this to the RUC, so we can get a number of them, so that it can be evened out. But it should only be filled out by people who commonly perform the procedure. So we try and send out a large number of surveys, hoping to get a certain number of them back. But do me a favor, if you get one and you perform that procedure, please fill it out. It just helps us out so much. And it's really kind of, I want to say, one's role in helping protect urologists to make sure that our procedures are appropriately valued. So please, take that to heart and do fill those out if you get them. If it is of a procedure that you do not do, please don't fill it out and don't make up stuff.
Thank you for that. I will add, we send out anywhere between 2,000 to 5,000 surveys and hoping for a response between 30 to 60, depending on the utilization of whatever procedure is being questioned.
But the more that we get back, the more that we're going to be believed that it's a good survey. And so please don't think someone else is going to do it. If you do it, fill it out. It's really important for the AUA to get these filled out.
Yes, thank you. Next question. What level does elevated PSA fall on the medical decision-making chart for problems addressed?
Okay, so great question. So again, thank you very much. So again, if you go back to the slide where we talked about the three columns, we've got our problems addressed, our data, and our patient risk. So elevated PSA would probably fall into a level 4, which is either going to be a problem that is not yet resolved, either a chronic problem that is not met its treatment goals, or it can be a new problem yet with that doesn't have a determination of the direction it's going yet. It's sort of like gross hematuria. It's a new problem that's with an uncertain prognosis. So elevated PSA can be a new problem with an uncertain prognosis. We don't know if the patient is then going to eventually be diagnosed with cancer. We don't know if the patient is going to have another PSA that's going to then come back down. So this is an uncertain prognosis. It would be a level 4, moderate, under problems addressed.
Great. And I believe this will be our last question. Well, what if a patient only comes in to have staples or sutures removed and the ancillary staff remove them? Can you bill 1583? I'm sorry, 15853 or 15854?
Right. So again, a great question about the suture and staple removal. Again, the way that the code is written is that this is performed by the provider or by a qualified healthcare professional, and is an add-on code to an E&M service. I would imagine that if an ancillary staff came in and removed 15853 or remove suture staples, they would not be a billable service because they wouldn't be able to bill it anyways. And this is not something that can be left for somebody else. So I would bill it if the provider themselves or someone, a qualified healthcare provider, performs the suture or staple removal.
Fantastic. And Dr. Rubenstein, I believe we've answered all the questions. However, I might have missed one or two. And if we did, again, we will get back to you by email if we have your email name in here. Dr. Rubenstein, very much appreciate your time and your volunteerism in putting this together and presenting for everyone. We thank you very, very much. And we thank everyone for being on today, and hope everyone has a fantastic day.
Thank you for listening. If you enjoyed this episode, make AUA Leadership in Business your go-to podcast. Subscribe today by searching AUA Leadership in Business on your favorite podcast app and enhance your leadership and business education needs.